Hi, I'm Mel Anne.
I'm Anne Woolfield.
And I'm Carla Pecoraro, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G. Last week we covered the basics of menopause, what it is, when it happens, what women experience, and what the long-term consequences are. This week we're going to run through how to approach a menopause consultation.
Let's say you're seeing Jessie. Jessie is a 52-year-old lady who's specifically booked in to see you for a discussion around menopause. How would you approach this consultation?
The first thing we want to do is let Jessie talk to us. What prompted her to make this appointment today? Is there anything in particular that she's worried about? Starting the consultation in this open-ended manner should give Jessie the opportunity to voice the concerns that are unique to her. What we're looking for here is to gain an understanding of the issues that are most important to Jessie and the symptoms that might be troubling her.
Jessie tells you that she's been hearing a lot about menopause lately and wonders whether her hot flushes and mood changes might be due to menopause. She says her friends have seen a big improvement on menopausal hormonal therapy and she wants to know whether it's something she should be on or not.
I'd like to learn a little bit more about the kinds of symptoms Jessie is experiencing. To do this, I would print the Menopause Symptoms Score Sheet from the Australian Menopause Society website and ask Jessie to complete it. This is a really handy little tool that lists about 21 different symptoms that are associated with menopause. Jessie would score the symptoms 0 to 3 depending on how much she thinks those symptoms are affecting her. From there, I would have a quick look over the score sheet and I can easily gain an understanding of the kind of concerns Jessie has that she may or may not have realised can be caused by menopause. The score sheet is also really useful after initiating treatment because you can have it repeated after about 3 months to check whether there have been any significant improvements.
What kind of symptoms does the score sheet cover?
Well, Anne, I'm glad you asked. This is the perfect opportunity for a recap of the symptoms of menopause. The common symptoms of menopause include hot flushes, night sweats, sleep disturbances, mood changes, brain fog, muscle and joint pains, and genitourinary symptoms like vaginal dryness, dyspareunia, or urinary frequency. If you don't use the AMS menopause score sheet, you can just ask Jessie if she experiences any of these symptoms and how severe she thinks they are.
Jessie completes the score sheet and we can see that her main concerns are vasomotor symptoms, sleep disturbance, mood changes and brain fog. What's next?
Since Jessie has mentioned mood changes, it's important to explore this a little bit further. Mood changes are a common symptom of menopause and include symptoms like irritability, depression, anger, and rage. But perimenopause is also a common time when women might experience depression and anxiety for the first time. Another useful tool here is the Meno-D questionnaire. This is a questionnaire that was developed by Professor Jayashri Kulkarni from Monash University and can be easily found on the internet. The questionnaire involves about 12 different symptoms that can be self-scored by the woman with reference to her premenopausal status. I find the questionnaire is quite useful to identify women with significant mood symptoms that require treatment, but it also helps to validate the way a lot of women are feeling and help them to realize just how much menopause is contributing to their mood.
The next important question to ask is about her menstrual cycles. If Jessie still gets periods, then we would be thinking about menstrual irregularities and whether they are troubling her, as well as the need to consider contraception in our management strategy. If Jessie doesn't get her periods, then we need to find out when her last menstrual period was. This will help guide us on whether a cyclical or continuous menopausal hormonal therapy approach is warranted.
Jessie hasn't had a period for about 8 months, but she did notice a big change in her menstruation in the few years leading up to her last menstrual period. Her periods became irregular and less frequent, and she reported that the duration seemed to change as well.
This is helpful information. Remember, menopause is a retrospective diagnosis made when there have been 12 months since the last menstrual period. So while we suspect Jessie is postmenopausal, we technically have to call her perimenopausal since it's only been 8 months. Because it's within 12 months of the last menstrual period, we should be considering contraception, and if Jessie chooses menopausal hormonal therapy, then a cyclical regime would be more appropriate than continuous. But we'll get to that later. For now, let's complete our workup.
Okay, so now we want to move on to a general medical history. You know the drill. O&G history, past medical and surgical history, medications, allergies, social history, and family history. But there are a few key points we're looking out for. The first is relating to cancer screening. We're talking cervical cancer, breast cancer, and bowel cancer. Are Jessie's cervical screening tests up to date? Has she had a recent mammogram? What about her fecal occult blood testing? Cervical screening tests should be performed every 5 years. Mammograms are recommended every 2 years for women over the age of 50 through the National Breast Screening Australia program, but are also freely available for women over the age of 40. Fecal occult blood testing is recommended every 2 years for women over the age of 50 through the National Bowel Screening program. These kits are usually mailed out. I would take this opportunity to make sure Jessie is up to date with all of her screening, and if not, ensure she makes plans to do so. We could perform a CST or give her the swab for a self-collect. Sometimes I'll even get the patient to book a mammogram during the appointment or request the fecal occult blood testing online. They're quite easy to do and they're so important, especially if we're considering starting MHT.
The next key point in the history is to look for red flags or anything that might be a contraindication or caution to starting hormonal therapy. The major contraindications to MHT are undiagnosed vaginal bleeding, hormone-dependent cancers, including breast and endometrial cancer, severe liver disease, acute cardiovascular event, acute venous thromboembolism, and porphyria cutanea tarda.
What in the world is porphyria cutanea tarda?
Porphyria cutanea tarda is a metabolic condition caused by a defect in an enzyme in the heme biosynthesis pathway. It results in a buildup of metabolites in the skin that leads to blistering, scarring, and photosensitivity. The reason hormonal therapy is contraindicated in porphyria cutanea tarda is because heme is required for the synthesis of the CYP450 enzyme, which is responsible for breaking down many medications, including oral estrogen. Estrogen can also trigger porphyria attacks, leading to breakouts of blisters and skin lesions. In patients in whom their porphyria is in remission, MHT can be considered, but you should aim for a transdermal route and make the decision in conjunction with their primary specialist.
Other conditions to be aware of include previous heart attack, TIA or stroke, a high risk of venous thromboembolism, active liver disease, migraine with aura, hyperlipidemia, hepatobiliary disease, a high risk of breast cancer, and age over 65 with no prior hormonal use. In most of these conditions, MHT isn't absolutely contraindicated, but it would be a much safer idea to use a transdermal estrogen rather than an oral estrogen. The reason is that oral estrogen is metabolized in the liver and is associated with a high risk of VTE, stroke, hyperlipidemia, and hepatobiliary disease. Women who are at high risk of breast cancer or who are aged over 65 are separate groups to consider, and we'll discuss those in more detail later.
Okay, so we've covered our symptoms and our medical history, particularly looking for cancer screening and red flags for MHT. Next on our list is to assess risk factors for the long-term consequences of menopause. What are the long-term consequences of menopause, I hear you ask? Well, let me remind you. The long-term consequences of menopause include osteoporosis, cardiovascular disease, and metabolic changes. First up, let's look at osteoporosis and how to do a risk assessment.
The best way to do a risk assessment for osteoporosis is to follow the flowchart on the Healthy Bones Australia website. Women at high risk of osteoporosis include those over the age of 50 with a hip or vertebral fracture. These women should be considered to have osteoporosis and should be offered treatment. For women over the age of 50 with a current or prior minimal trauma fracture to other sites, so not to the hip or vertebra, you should use a DEXA BMD scan to help stratify their risk. All other women should have a formal risk assessment done to assess for the presence of any conditions or medications that would warrant a DEXA scan. These include early menopause, hypogonadism, celiac disease, rheumatoid arthritis, primary hyperparathyroidism, hypothyroidism, diabetes, chronic liver disease or moderate to severe kidney disease, myeloma, organ or bone marrow transplant, and HIV. High-risk medications include glucocorticoid use for more than 4 months at a dose of more than 7.5 milligrams per day, excessive thyroid hormone replacement, androgen deprivation therapy, and aromatase inhibitors. Patients who meet these criteria should have a DEXA scan. If your patient doesn't meet any of these criteria, then you want to consider their lifestyle factors. Lifestyle factors include age over 70, a parent with a hip fracture, falls or poor balance, low physical activity or mobility, low body weight, low muscle mass, protein, calcium, malnutrition, vitamin D insufficiency, smoking and alcohol consumption of greater than 2 standard drinks per day. A simple way of doing this assessment is to use the FRAX calculator, FRAX. If the 10-year probability of a major osteoporotic fracture is more than 10%, then you should arrange a DEXA scan.
Righto. And how do we do that?
A DEXA is dual energy X-ray. It's used to detect bone mineral density. It involves a special type of low-dose radiation X-ray to the hip and spine that can detect even small amounts of bone loss. Sometimes the forearm might also be scanned. Because bone loss occurs throughout the entire skeleton, you can get away with assessing the bone mineral density of just a few bones rather than having to X-ray the entire body. DEXA scan results are reported as T-scores. A normal T-score is greater than minus 1.5. A low bone density is considered to be a T-score between minus 1.5 to minus 2.5, and osteoporosis is considered to be a T-score of less than minus 2.5.
Assessing the osteoporosis risk is important. We know the risk of osteoporosis increases after the menopause, which means that the chance of a minimal trauma fracture increases. The main fracture we worry about is a hip fracture, since these fractures are associated with a high mortality rate. In patients with osteopenia or osteoporosis, menopausal hormonal therapy may actually be indicated on that basis alone, regardless of her other menopausal symptoms.
Next, we want to move on to cardiovascular and metabolic risk factors. These ones are pretty straightforward, and they include obesity, diabetes, hyperlipidemia, hypertension, chronic kidney disease, smoking, and alcohol consumption. This typically involves taking a blood pressure, measuring the height and weight, and arranging a well-woman screen with some bloods. Blood tests that should be organised include a full blood count, a ferritin, UEC, LFTs, lipids, TSH, and a HbA1c if indicated. Assessing the cardiovascular risk factors is really important because it gives us an opportunity to offer some lifestyle advice and management options for preventative care. But it also gives us an opportunity to talk about the cardiovascular benefits of menopausal hormonal therapy if the woman chooses to go down that pathway. Commencing menopausal hormonal therapy within 10 years of menopause is associated with a reduction in cardiovascular events.
The final question is to ask whether Jessie still has a uterus or not. This allows us to determine whether we need progesterone as part of our MHT strategy. Estrogen is the most useful part of MHT, but if we just give unopposed estrogen when the woman has a uterus, then we're going to significantly increase the risk of endometrial cancer. Women with a uterus need progesterone to counteract the estrogen and protect the endometrium from overgrowth. Women without a uterus don't need progesterone since they don't have an endometrium that needs protecting. The one caveat to that is women with severe endometriosis. In these women, endometrial deposits are often outside of the uterus, and so there's a small risk of activating these endometriosis deposits with the use of estrogen alone. For this reason, patients with severe endo who have had a hysterectomy may still be recommended to take progesterone.
Okay, back to Jessie. Jessie is up to date with her cervical screening and fecal occult blood testing, but she hasn't yet had a mammogram. You get her to log into Breast Screen Australia and book an appointment, and she schedules herself in for her first ever mammogram. Jessie still has a uterus and she's sexually active, so we'll need to consider combined hormonal therapy as well as the role of contraception. Otherwise, Jessie has no significant medical history, has no contraindications to menopausal hormonal therapy, and has no risk factors for osteoporosis.
So now that we have a comprehensive understanding of Jessie's primary concerns, her menopausal symptoms, and her medical history, we can start to talk about management options. These include lifestyle management options, hormonal replacement therapy, and non-hormonal management options.
Lifestyle management options are really important, and they're often overlooked, so we're going to start here. The first part of lifestyle management is maintaining a healthy weight. Women who are overweight are more likely to experience severe hot flushes, not to mention the general health risks of obesity, including endometrial cancer, breast cancer, and cardiovascular disease, just to name a few. Weight loss of about 10% has been shown to reduce the severity and amount of hot flushes. Now, just telling someone to lose weight is not very useful, and you need to be practical about it. I often recommend the patient has a good discussion with her GP about weight management options. This might include a referral to a dietitian, use of a personal trainer, and even the use of weight loss medications, of which many are currently available. Exercise itself does not seem to have any impact on hot flushes, but it does reduce the risk of cardiovascular disease and improve general health and well-being, so we do recommend it as a part of a healthy lifestyle. Exercise of about 30 minutes 5 times a week is the general recommendation. This should include a combination of cardio and weights. Resistance training is important to maintain bone mineral density, which becomes increasingly important as the risk of osteoporosis increases with age and menopause. Yoga also has a lot of health benefits in terms of maintaining flexibility and balance. What a lot of people may not realize is that regular exercise significantly reduces the risk of breast cancer, which is a huge issue that women worry about after menopause. Exercise has also been shown to improve cognitive functioning, depression, sleep patterns, and fatigue, so we should always be encouraging women to move their bodies. Diet is also incredibly important, and there are a number of dietitians with a special interest in menopause who can be very helpful in guiding women through their nutritional needs in the menopause.
Smoking cessation and reducing alcohol consumption can also be helpful. Often these are triggers for vasomotor symptoms, and reducing intake might reduce hot flushes. Reducing alcohol consumption can also lower your risk of breast cancer. Just 2 standard drinks a day is enough to raise your breast cancer risk beyond the risk often reported with MHT. Crazy, right? Everyone always talks about MHT increasing your risk of breast cancer, but no one ever talks about those 2 glasses of wine a night.
You may also want to discuss cooling factors that can help reduce hot flushes. Now, there's not a whole lot of evidence for these suggestions, but if you're feeling hot, it makes sense to know how to cool yourself down. Some suggestions include dressing in layers or wearing clothing made of natural fibers that can breathe, avoiding jumpers and scarves, using a hand fan or electric fan as needed, keeping cooler at night by lowering the room temperature or putting a cold pack under the pillow, using a bed fan that blows air between the sheets, and drinking cool liquids such as iced water.
Mind and body-based practices can also be very useful for women in menopause. CBT is effective at reducing the impact of vasomotor symptoms and improving sleep and general well-being. Paced breathing, relaxation, and mindfulness can reduce the feeling of anxiety associated with hot flushes. And interestingly, hypnosis has also been shown to have some improvement on hot flushes and sleep.
Then we have hormonal management options. These are by far the most effective management options for menopause, especially vasomotor symptoms. Our options here include combined hormonal replacement therapy and estrogen-only menopausal hormonal therapy. Combined MHT involves a combination of estrogen and progesterone and is recommended for women with a uterus or those with severe endometriosis. Combined MHT is typically used cyclically in perimenopause and for the first year after the final menstrual period, whereas continuous MHT is used after 1 year of cyclical MHT or after 12 months beyond the final menstrual period. Cyclical MHT contains daily estrogen and then cyclical progesterone used for about 12 to 14 days. Continuous estrogen contains daily estrogen and then essentially daily progesterone. The reason why we don't suggest going straight to continuous MHT in the perimenopause or shortly after menopause is because there is an increased risk of breakthrough bleeding. MHT comes in a combination of options ranging from topical gels and topical patches to oral tablets, with dosing ranging from low to medium to high. Estrogen-only MHT is reserved for women without a uterus. It should never be prescribed alone for women with a uterus because of the risk of causing endometrial cancer. Estrogen comes as a topical gel, a transdermal patch, and oral tablets. There are also vaginal preparations of estrogen, which are useful for genitourinary symptoms. Tibolone is another hormonal option, but is technically a steroid hormone. Tibolone has estrogen effects on vasomotor symptoms and bone, progesterone effects on the endometrium for endometrial protection, and androgenic effects for libido and energy. The AMS Guide to MHT Doses provides a good summary of the available hormone replacement preparation options available for patients in Australia. Conveniently, there is also one for those in New Zealand, since availability of different medications varies by country. I usually print this out and go through the different options with the patient to help decide which one might be the best one to start with.
Our non-hormonal management options include fezolinetant, otherwise known as Veoza, clonidine, gabapentin, pregabalin, SSRIs and SNRIs, oxybutynin. These are predominantly used for hot flushes and are much less effective than conventional MHT. They are still important options to be aware of since MHT may not be appropriate in every woman.
The menopause consultation should include a discussion of all available hormonal and non-hormonal options, as well as a recommendation for what option might be best suited to the patient, depending on her individual symptoms, risk factors, medical history, and her preference. It's important to discuss the risks and benefits of all options, as well as the side effects and the expected follow-up for the patient. We recommend printing the appropriate information sheets from the Australian Menopause Society website and giving it to the patient.
For Jessie, her symptoms encompass vasomotor symptoms, sleep disturbance, mood changes, and brain fog. She is within 12 months of her last period and she still has a uterus. She has no red flags or contraindications to treatment and her cancer screening is all up to date, or at least it will be once she gets that mammogram. Our key considerations here are the need for contraception and the recommendation for cyclical combined MHT. In general, we would start with a low-dose preparation and work our way up as needed. If we look at our AMS Guide to MHT Doses guideline, we can clearly see what our options are here. The Femiston tablet or Estrogel Pro, which is a combination of transdermal estrogen gel and micronized progesterone tablets. Medium dose options include trisequins, Femostin, and Astalis patches. Jessie also has the option of topical estrogel and having a Mirena inserted. This would provide the benefit of contraception as well as endometrial protection. So here we would consider Jessie's preferences. Would she prefer a tablet, a gel, or a patch?
Jessie is pretty keen on just taking a tablet, and she certainly has no risk factors that would suggest that she needs to take a transdermal estrogen instead of an oral estrogen. So she decides to take Femiston. She's aware that she still needs contraception, but she chooses to use condoms instead. What kind of follow-up should we arrange for Jessie?
In general, patients commenced on menopausal hormonal therapy should be reviewed in 3 months for effect and then annually.
Okay, so this has been a brief overview of how to run a menopause consultation. We'll go into the specifics of menopause management next week. So let's recap what we've learnt. Open the consultation by inviting the woman to express her concerns. Ask about symptoms such as hot flashes and night sweats, mood changes, urinary frequency, vaginal dryness and dyspareunia, sleep disturbance, brain fog, and musculoskeletal pains. Use the AMS Menopause Symptoms Scorecard to help understand the severity of her symptoms. Explore mood symptoms further using the MenOD questionnaire, and discuss bleeding patterns, including the final menstrual period, and determine the need for contraception.
Take a thorough medical history, paying close attention to cancer screening, CST, mammogram, FOBT, contraindications and cautions to the use of MHT, risk factors for cardiovascular disease, and risk factors for osteoporosis.
Contraindications to hormone replacement therapy include undiagnosed vaginal bleeding, hormone-dependent cancers including breast and endometrial cancer, severe liver disease, acute cardiovascular event, acute VTE, and porphyria cutanea tarda.
Precautions for MHT, where you might consider transdermal estrogen, include a past heart attack, TIA or stroke, a high risk for VTE, active liver disease or migraines with aura, hyperlipidemia, hepatobiliary disease, a high risk of breast cancer, anyone aged older than 65 with no prior history of MHT.
Cardiovascular risk factors include obesity, diabetes, hyperlipidemia, hypertension, chronic kidney disease, smoking, and alcohol consumption. Perform an osteoporosis risk assessment to determine the need for a DEXA BMD. Use the Healthy Bones Risk Assessment and FRAX calculator. And finally, determine whether the patient has a uterus or not.
The next thing we need to do is discuss management options, which include lifestyle management, menopausal hormonal therapy, and non-hormonal therapy.
Lifestyle management includes weight management, exercise including weight-bearing exercise, avoiding alcohol and smoking, cooling strategies for hot flushes, CBT and mindfulness to reduce the impact of hot flushes, and dietary changes.
Menopausal hormonal therapy options include continuous or cyclical combined MHT, estrogen-only MHT for those without a uterus, tibolone. MHT options can come as a topical gel, transdermal patch, oral tablets, or a combination. Cyclical MHT is used in the perimenopause and with 12 months of the final menstrual period, and continuous MHT is used beyond 12 months since the final menstrual period.
Non-hormonal options include fezolinetant, clonidine, gabapentin, pregabalin, SSRIs or SNRIs, and oxybutynin. Options discussed should involve a discussion around the risks, benefits, side effects, and expected follow-up, which is usually at 3 months after commencement and then annually.
Thanks for listening to this week's episode of the Uterine Sound podcast. Join us next week for a thorough discussion on menopause hormonal therapy and a special episode from Anne on the WHI trial.